Hello, everybody. Thank you for joining today's webinar, How War Shapes Healthcare in Syria and the Region. My name is Anthony, and I'll be moderating this webinar as part of the webinar series, The Syrian Revolution, A History from Below, which is co-hosted by the Global Campaign of Solidarity with the Syrian Revolution, as well as Warscapes and the Alliance of MENA Socialists. The credit for putting together this panel or this webinar goes to Yazan Al-Saadi, a journalist and writer who has worked with MSF in Lebanon, and who unfortunately won't be able to join us for the first half of the webinar because of connectivity issues in Lebanon, but will hopefully be able to join us later in the discussion as a discussant. We have a great panel of speakers today who I'll introduce shortly, but first we wanted to give a short introduction on why we are holding this webinar on how war has shaped healthcare. As we will hear from our panel of speakers, war has played a fundamental role in how healthcare has been shaped across the entire region. We will focus on the regionality of this and how healthcare has been politicized and even weaponized across since 2011, but even before as well, according to different contexts. Since 2011, we have heard stories of attacks on medical workers, attacks on ambulances and hospitals, and also how healthcare has been weaponized against protesters and dissenters across many countries in the region, from Bahrain to Iraq to Yemen to Syria, Libya, and many other countries besides. In this way, healthcare war and conflict connects across the entire region and in many ways reflects its geopolitics, which I think will be one of the core substances of this discussion. Health is also an issue that everyone is implicated in. We want to emphasize that it's not only the medical workers and healthcare workers who are involved in dealing with the fallout of war who are or should be concerned with healthcare, but that the main objective of this panel in the end is also to reach an understanding that healthcare is not just an issue that concerns narrow sections of society, but is a political issue that requires also some form of political response. Each speaker on today's panel is going to focus on different parts of this, and I'll introduce them shortly. Every speaker will have 10 minutes to give their intervention. After these 10 minutes each, we will have a question and answer period. But first, I wanted to announce the next panel in this webinar series on the Syrian Revolution, on capitalism and class struggle. It's the 6th webinar series. It will be held on Wednesday, July 15th at 2 p.m. Eastern Standard Time. And it will include Yasin Al-Haj Saleh, Miriam Abbabsa, Jihad Yaziji, and Samir Aboud. So to first announce our first speaker, we'll first be joined by Ossama Tanous. Ossama Tanous is a pediatrician and a researcher based in Haifa, a policy analyst for Al-Shabaka who researches structural violence and health disparities, and is currently studying a master's in public health. So, Ossama, your interest is in structural violence. You're a pediatrician with particular experiences in Palestine, and specific experiences also with the question of war, conflict, and healthcare, which has been experiences that have been ubiquitous across under occupation. Can you tell us more about your analysis of how war has contributed to shaping healthcare in Palestine?
Yes, thank you, Anthony, and thank you, Yazan, for hosting this panel and for inviting me, and thanks to the audience for joining. I hope you're doing well and safe. So I would give the inside view from Palestine, Israel, and try to demonstrate how it is completely different from the region. So Israel is a settler colonial state, right? It has been built as a settler colony, meaning based on settlers who travel across space and time in order to establish their sovereignty, right? So unlike migrants or refugees who travel in order to integrate in an existing political structure, settler colonies settlers and settler colonial states travel in order to establish sovereignty. And in this establishment of sovereignty and of settlements, that takes every aspect of life, whether it's trade, academia, agriculture, and healthcare, of course. So healthcare in the Israeli context, in the Zionist context, has been militarized since day one because the settler project is militarized since day one. So it would be very hard to make a clear discussion between what is civilian and what is military if we look at in Palestine in the 20s or 30s, because you had an ongoing settler project trying to expand and take more land. So in this context, healthcare has been, first of all, a goal for itself for creating a healthy nation. All this pre-nation building mythology of creating a healthy Jewish nation. And it is a precondition for settlements, right? You need to be healthy in order to fight, to be a good soldier, to occupy more land. So since day one, everything has been completely militarized in the Israeli context. And it's enough to have a quick look at the location of hospitals. If we look at Haifa and Jerusalem, for example, the hospitals are located on the tops of mountains where, where like most of the Palestinian population would live near the coastal area in Haifa, but that was also a strategic point. So the different sick funds, the different health funds and hospital were just an infrastructure for the settler colonial project and was heavily militarized. And if we look at the records of the Haganah, for example, the paramilitary Zionist militias, they would see that they would have two branches, the hospitals and the healthcare funds, where they're standing healthcare service provider, and what's called Magen David Adom, the Red David Shield, the Jewish equivalent of the Red Cross, would be the mobile service provider. So that has been heavily militarized since the beginning, and that had gained even more practice in World War II, and played a crucial role in the Nakba in the 1948 war. And the different military hospitals were operated all across the city, all across the country, and later on became, civilian, if we want to call them that way. So just like anywhere in Israeli society, it's very hard to draw a line between what is military and what is non-military. And the careers of doctors would often zigzag between being an army doctor in the military and then coming back to the hospital to become a civil doctor, and so on and so forth. If we would go with the timeline to the 67 war, when the occupation of the West Bank, Gaza, Julan, and Sinai. In this sense, healthcare has shaped war and military occupation has completely shaped the healthcare of the Palestinian, the landscape of the Palestinian healthcare structure, because being under military occupation, it had no sovereignty, so people could not really plan, any sort of what is the needs of the community and how do we plan that. And of course, you have active military occupation, checkpoints, different military operations, on and on. And this is why, if we would look at the mirror side, the Palestinian healthcare system, it is heavily divided, and it is just a chaotic mishmash and network of different providers who try to provide different healthcare, whether it's the private sector, the governmental sector, NGOs, and different hospitals. So in Palestine, militarization has been the process since day one, and it is a bit different than a post-colonial or nation state in the region like Iraq or Syria, where things have turned out that way differently. It's still important to show that Israel has found a way into fusing this military medicine with what it calls humanitarian medicine. So the Israeli army having a medical corps that was shaped from the 30s and 40s would go into missions, different humanitarian crises, whether it's an earthquake in Mexico or Haiti, or a genocide in Rwanda or Kosovo, and so on. And would use these tactics that it has used and acquired in military in order to operate in these operation, and frame that under humanitarian medicine, and use that again as a public relation machine for Israel, as a tool to whitewash Israel. So if we would want to conclude, I would say that war has, in this case, settler colonization has intimately defined, not only shaped, it has created healthcare system. Healthcare was created from the beginning to be and to follow an infrastructure, to follow settlements, to follow settlement expansion. And we can see that going until now. Even if you look at the occupied West Bank, settlements like Ariel are having their own medical university and starting a medical center under military occupation, and still framing that a bit in a humanitarian way. So it has in the past, and it continues, because the settler project is an expanding one. And this, of course, had played largely in the pandemic. The pandemic has, of course, militarized medical discourses all over the world. But in Israel, being a heavily militarized society, this whole notion of doctors being brothers in arms, being in the front, being a medical corps, fighting the virus, fighting the pandemic, and so on, it all has been deeply militarized. And here we can note that even Palestinian doctors working within Israeli healthcare system have been a part of this normalization of the militarized discourse of settler symbols, settler militarization, and that has affected Palestinian as well. Thank you.
Wait.
Excuse me, everyone, I was on mute. Thank you, Ossama. Next, we're going to hear from Omar Dewachi, Associate Professor of Medical Anthropology at Rutgers University. Until recently, he taught social medicine, global health, and anthropology in Lebanon, and was part of founding the conflict medicine program at the American University of Beirut, and the author of this book, Ungovernable Life, Mandatory Medicine and Statecraft in Iraq. So, Omar, you've been paying very careful attention to this topic for a while now, and you've worked on the medical travel of Iraqi patients. You've worked on how war drives antimicrobial resistance, and you've been working on conceptualizing conflict medicine as such. Ossama has told us quite a bit about militarization and the politics of healthcare under occupation. Your work, meanwhile, focuses somewhat more on Arab states and these sort of politics within the under the Arab states of the region. Can you tell us your analysis of how healthcare has been transformed by regional war?
Thank you, Anthony, and thanks for inviting me for this really wonderful panel. And although the topic is a very grim topic, so we apologize for all the grimness that comes with it. But I'm hoping that this kind of sheds more light on the centrality of health and healthcare to understanding the region in terms of more its present and it's also its historical past. So let me start a bit with a more of a global bird's eye view on this, and I'll kind of more descend in scale into kind of a more micro analysis. So the one thing that is really this pandemic event right now that we are living through has highlighted is this kind of the centrality of health to global history and to kind of politics in general in different parts of the world. However, if we, for those who study healthcare events and study healthcare in historical and anthropological and sociological perspectives, these things are not new, and they have a long history that actually connects different parts of the world in different ways. So, for example, historically, most global, or at least pandemics in Europe, from the plague epidemics in the 16th century to the cholera epidemics in the 19th century, have been actually very seriously interconnected with the Middle East region. The plague epidemic actually a lot of the times was blamed, the region was always blamed as being a reservoir of the plague that kind of gets transmitted into Europe through commerce and trade. The first actually international health treaties on cholera, which actually is the first international health treaty, was a response to the kind of the scare of pilgrimage to Mecca in the mid 19th century. So, and over the kind of the decades of the 20th century, the First World War Second World War were very instrumental in also shaping the healthcare conditions, and health itself was very central in shaping the outcome of these wars. My focus really has been two sides in this kind of complicated history. At one level, I've mainly been focusing on Iraq and the history of healthcare in Iraq in relationship to how healthcare and health events have been central to the history of state building in Iraq and across the region. Starting from the First World War, the one of the main challenges that faced the British occupying force was healthcare. Actually, the British lost more people, more soldiers to cholera and heat strokes and diarrhea than actually during actual battle. And in many ways, as some historians have shown, the experiences of war have actually changed how healthcare is perceived and how healthcare became central to any kind of political project or military project in terms of these occupying armies, or in projects like the Mandate or state building. And that's kind of what I tried to show in my book on the history of healthcare in Iraq, is that healthcare played a very central role in most this history, specifically in the history of the Mandate, the history of development projects in Iraq, and actually very much played a critical role during the Iran-Iraq war. The building of Iraq's healthcare had been also completely attacked and dismantled under decades of Western interventions from the early 1990s. The Gulf War and the sanctions were actually attacks, can be seen as attacks on healthcare, and a kind of a more of a structural dismantlement of the country's healthcare infrastructure. These kind of events, and of course followed by the occupation in 2003 and the civil conflict and the civil war that erupted in Iraq, healthcare became one of the central platforms of the struggle in the country around, and militarized struggles in the country between the different militias and the different kind of gangs and the different kind of fighting groups, and people of course got caught up in these dynamics. So my research had been trying to really think about what does it really mean to think about health and healthcare as a kind of the lens into understanding these histories of state making and unmaking in the region, rather than taking a more ideological kind of readings of how just the states are posturing itself in discourse or posturing itself in terms of the ideology of ruling parties. Focusing on health had kind of allowed to open up more questions around everyday life and around population health and around movement of populations, around training of doctors, around building healthcare infrastructure in many of these societies in the Middle East. Taking on that lens allow us to see this kind of history coming in from below, because it allows us to understand the nuances that happen beyond certain kind of ideological discourses around health and politics. So in many ways, health could be seen in that kind of setting as a lens into understanding political, social, economic, and technological transformations over time. The second kind of intervention that I've kind of been concerned with, which is what Anthony was referring to, is my interest in conflict medicine and tracing what I've been calling the ecologies of war, and I've been doing that through looking at war injuries on really kind of descending from the level of population health into the level of kind of individual and collective bodies that get affected by the war. So one of the really incredible things to see during the past couple of decades of conflict in the region is the movement of different populations from Iraq to Syria, from Syria to Lebanon, from Iraq to India, from or to Jordan. What we've seen since over the past the past decades or 2 decades now, is that healthcare is a very central question in terms of how people seek care. People refuse to go to places that are governed by kind of the other side, of course, even though they might be close to them. And many in Iraq, this has kind of led to a kind of a displacement of patients seeking healthcare across the region. And these were not only just patients who had money, but actually even the Iraqi regime started funding people to travel abroad and seek healthcare. So what this movement of these different patients, and of course with the displacement across the region, the map of healthcare has been redrawn in so many different ways and continue to be redrawn, not only because of these wars, but also due to it's been also shaped by a lot of the humanitarian interventions. So one of these kind of things that we've seen, like some of the points that I would like to kind of throw at the table here is that the weaponization of healthcare is not necessarily a new phenomena, and is not necessarily just only linked to the Syrian conflict. It can be seen, as I've kind of written before about this, it could be seen in the history of attacks on healthcare through sanctions in Iraq, or destruction of civilian infrastructure. And also these kind of effect of these wars and how they contribute to the exodus of doctors abroad, seeking kind of better careers and seeking security elsewhere. The major kind of effect also over a long period of time, and we see this in Iraq right now in terms of the rise of cases over the past few weeks with COVID-19, is that there has been a complete lack of trust in the country's healthcare system, and this is kind of something that has been evolving over the past 2-3 decades of conflicts in Iraq, and this is something that one needs to be thinking about. In many places of conflict, even after the conflict ends, you get a new mode of interaction around the healthcare system. So the destruction of infrastructure, the loss of trust in the healthcare system, the exodus of doctors, and also the deterioration of the ecology of affliction in the country. What we've been seeing is that with environmental contamination of the war, with the lack of any kind of infection control, hospitals become very dangerous places for people, and what we see kind of reluctance right now in places like Iraq, of people going to hospitals because they know that they go into the hospital, actually they will catch something else. Even if you have COVID-19, you might die from an antimicrobial resistant infection, or from mistreatment, or kind of lack of guidelines. So health can really, or kind of these questions of health can really give us an insight on a very kind of everyday level of how people negotiate their survival, how these different populations are kind of condemned into living in certain kind of conditions, which actually, not only that these conditions are conducive for injury and being affected by disease, but actually it keeps on, like recurrent forms of injury happen all the time. So I'll stop here actually, and I'm very curious to hear more from my colleagues, and actually looking forward to the conversation that will ensue after this. Thank you very much.
Thank you very much, Omar. Also, a reminder for the people listening to us to write down your questions and comments, whether you're on YouTube or on Facebook, and we will try to feed those into the discussion as well. Next, from our panelists, we'll be hearing from Khuloud al-Saba. Khuloud is a PhD candidate in social policy at the University of Edinburgh. She has worked extensively in the development and humanitarian sector in Syria and Iraq, with many organizations, too many to list, but some of which are ICRC, MSF, UNICEF, UNDP, as well as with the Syrian Center for Policy Research and the Red Crescent communities in Iraq, Syria, Lebanon, and Jordan. So Khuloud, you're a doctor, you're a humanitarian on the ground, you have this wealth of experience across a very large amount of time in different wars and different conflicts in the region, looking at healthcare. What can you tell us about these different contexts? And especially, I think it would be great for us to hear, what could you tell us about similarities and differences across these contracts, in terms of place, but also across time?
Well, hello. Thank you for having me, and especially among all these amazing colleagues. It's really interesting to hear everybody's intervention, and I will be also interested in listening to what Aula is gonna bring in on the table for Syria and neighboring countries. As you said, I'm working on militarization, and I'm working on social determinants of health or political determinants of health as an overarching framework to understand population health. And in the case of Syria, it can't be more perfect, unfortunately, because historically healthcare is one of the manifestation of the social contract between the population or society and the state. And as Omar said, as Ossama said, we heard different states around in the region. The difference between the intensity of the level of the militarization of the state, but then also what they have in common. Authoritarian states have usually conditional access and conditional contracts with citizens or with the population, depending on loyalty. And also after loyalty comes all kind of indicators, differential indicators like class, gender, geography. In case of Syria, this was the case before the war started, but then when the revolution started and then the war afterwards, the overarching determinant and change was the level of violence in the institutions, level of violence between the state and the population, level of violence translated into between communities and different groups, and that can mainly be seen through different levels of a macro and a micro impact and instrumentalization of violence. So, for example, we can see, before anything else, we can see that all the resources, not only from health, but also education, all kind of social care has been diverted to the military expenditure. Also, all resources in healthcare were directed toward the military, in a sense that this is the new hierarchy in the society where the men who defend the country are on the front line, who deserve our resources. On another level, the spaces of healing, or if this is a way to describe clinics and hospitals, turned into part of the strategy of urban militarization and urban warfare, where buildings, healthcare workers, all used as an instrument to force a control or force a situation. For example, sieges, starvation. All these were strategies where healthcare was involved in as a weapon. So, for example, many areas in Syria, and I think still that affected the infrastructure, the building infrastructure for the healthcare. For example, in Syria, you can see right from the beginning, even when the protests started to happen, hospitals, just like Ossama mentioned, hospitals in Syria are built also on hills. And this is a very interesting a trend in the Middle East. I now remember also in rural areas in Iraq, the hospitals also built higher than the rest of the cities. And immediately these spaces turned into sniper centers for the army and for the security forces. And it was, I visited many hospitals who kept their doors open, still being turned into this military bases, and also at the same time providing care for patients. But you can see the the quality of patients in these spaces. Usually, many women, men would never be seen close to the hospitals, etc. The second thing after the infrastructure destruction is the displacement of the population. Originally, people have their own safety networks. We weren't in a perfect situation. We were in a situation that people had their own safety networks and they build up a resilience accordingly to their position in the society. But then the war happened and and I think displacement is something that we can associate with every war and conflict in history. But the war happened in Syria, and massive displacement happened in consequence to the urban warfare. All parties involved in the war took over city centers, took over urban centers, and they fought from one building to another. So you can see we ended up with hundreds of thousands of people moving, even sometimes in the same day. Made the response to that really complicated. So displacement was a massive issue where all the safety networks compromised. Everything we know it. People, families, everything we know has changed. People usually make relationships with healthcare providers and sustain them in order to attain not only care, but also more of a complex treatment plan, if you want to say. Societies in the region, like Syria and Iraq, Jordan, Lebanon, Palestine, we're heading toward an aging society, but also we're having a massive chronic diseases burden that happens now way earlier in ages in demographic groups than other nations in comparison. And this is also related to violence. And the response to such diseases and complications need complex systems working on the ground. At the end, at the moment, now we have, if you want to call it healthcare, although I would be very cautious to call it healthcare system. But if at the end we have 4 different healthcare operating now in Syria, and government-controlled areas and opposition-controlled areas in northeast Syria, and Kurdish-controlled areas and Turkey-controlled areas, all of these systems, what we have in common are that they are fractured systems. They depend massively on external resources and NGO programs, and these programs and resources are not built to respond to a complex situation. We've seen this in Iraq, we've seen it in Afghanistan, we've seen it in many other cases, but unfortunately the lesson keeps turning. I would say it would be very interesting for sociologists and healthcare to look at how different indicators, how different social qualities and privileges work out in relationship of the population with the healthcare under violence, how gender is affecting us, how power relation in the houses and the households, ability to move and across the checkpoints, etc. All of these are things yet to be studied, and I think, although they are old story, just as Omar said, it's not massively. The situation in Syria is quite intense, and it is one of the most documented conflicts in the world. So we can see everything. We saw everything. We saw every hospital. We saw every health worker. We saw every child. And we saw every fighter. But the problem is still there. The type of strategies used by powerful actors in a conflict zone are the same. You instrumentalize healthcare workers and healthcare centers to control the population. You instrumentalize disease, also you instrumentalize food, etc., to control the population. This is against IHL. This is against all kind of let's say, the international law treaties, but the reality, this is it. But it didn't start in Syria. It started in Iraq, started in Afghanistan, started in Palestine. The tactic of attacking hospitals is a tactic based on a wide use tactic in war on terror that the American army used in Afghanistan. But every other state is adding their own flavor. Like, for example, we use barrels instead of rockets and high advanced rockets. It's all very repetitive, unfortunately. The second thing that I want to talk about is against violence is also the role of health workers, and I think Aula is gonna tell us more about this, and I think she worked more on the issue of health workers. But I want to say that also a perspective on the role of health workers and how it changed during the conflict. And it's important for me as a person who organized it through the protest to see how there's a massive change between a health worker who used to be a social agent, a community leader, a participant, to a neutral person because of the humanitarian response. We had this new image enforced on health workers as they have to be neutral, they have to show that their institutions, they have to show that their patients are certain kind of people or certain kind of groups. And this is massively disruptive. This is massively disruptive to the healthcare itself, but also massively disruptive to the communities themselves in a way of how they build resilience, because health workers, teachers, at the end are social agents. They are the social agents of change anywhere else. And this attempt to neutralize them or diffuse their politics is not very healthy. It's not going to reflect in a better situation. And as Omar said, and I think this is definitely the situation in Syria also now, the trust in health workers and trust in health institutions is deteriorating to a degree where when we have something as COVID, you have people avoiding hospitals, because of course they are avoiding the contraction of the virus, but also because there is eroding trust between the institutions and health workers and the population. And that will be it from me. And I'm very excited to hear what Aula has to say.
Thank you very much, Khuloud. Our next speaker today is Aula Abbara. Aula Abbara is an infectious disease doctor who works at Imperial College London and co-chairs the Syria Public Health Network, a group which brings together academics, NGOs, policymakers, and international organizations to influence policies relevant to public health in Syria, or the public health of Syrians. She also works with SAMS, the Syrian American Medical Society, and was a collaborator on the Lancet Commission on Syria. So Aula, we heard a lot from Khuloud now about the situation on the ground in Syria as well as in other places. You also have extensive experience there, and especially in areas outside of the control of the Assad regime. Can you tell us a bit more about the dynamics at play there?
Yes, absolutely. So firstly, thank you very much for asking me to speak this evening. I'm in London, so it's evening, so I don't know where our other panelists are today. And also, it's been such a privilege to listen to the preceding speakers. It's wonderful to speak after Khuloud because she has made so many important points, and I'd like to draw some of these out. And I think the very first, most poignant point is we can now no longer talk about Syria. So Syria in itself as a country doesn't exist. Syria is fragmented. As Khuloud said, there's more than one health system functioning within it. Different parts of Syria are under different political powers. So you've got the government areas, the northeast, the northwest, areas under Turkish control. And the important thing about healthcare when we discuss this fragmented, politicized health systems functioning within the country is that each have their own way of governing, leading different strategies, and also different ways of running the health facilities within these different health systems within these areas, different adaptations and innovations, and also different access to international and humanitarian aid. And this is something that's very poignant at this point in time, because the areas in the northwest and northwest of Syria in particular relied very much on cross-border aid. So in 2014, the first UN Security Resolution, UN Security Council resolution on cross-border aid was released. And this allowed 4 border crossings for health and humanitarian aid to enter Syria. And the reason for that is, if humanitarian aid was given through government-controlled areas, so through Damascus, and it was to reach cross-line, this very much and very often did not happen. And it meant areas were effectively cut off from international aid and certainly didn't have the right provisions that they needed. At this second, we are on tenterhooks because there are 2 border crossings in northwest Syria where 3 to 4 million people rely on this cross-border aid, and they're now being subject to discussions in the UN Security Council in terms of being renewed. The importance of this is now when we think across the country, we see different levels of destruction across the country. We've spoken about the weaponization of healthcare. And what we mean by this term is the deliberate, multidimensional and systematic attacks on different aspects of healthcare. And that's everything from the health facilities that we've heard, but also on healthcare workers themselves, interrupting the delivery of medical aid, and that was particularly poignant for areas that were under siege. So in Syria, in the last few years, up to 2 to 3 million people had been under siege or in hard to reach areas, and they were starved of medical care with very few health workers working in these areas. In terms of the attacks on health facilities across Syria, there have been hundreds. And I think it's important to say that all parties in this conflict have been culpable. So everyone from the government of Syria to Russia, other government of Syria allies, opposition forces, Daesh. But it's also important to note that more than 90% of these attacks have occurred at the hands of the government of Syria and its allies. We've begun to speak a little bit about Syrian healthcare workers, and this is so fundamental. So I'm a practicing physician in the United Kingdom, and I am grateful every single day that I can go to work. I am not threatened. I don't need to worry about resources. I can report cases, whereas this is simply not a fact in Syria. So very early in the Syrian conflict, so if we remember to March 2011 is when the protests first started, and by and large for the first few months they were peaceful. By the middle of 2012, they had become increasingly violent, mainly because they were being put down violently. And so in July 2012, a counter-terrorism law was passed, which criminalized the provision of healthcare to civilians in opposition areas. What this meant as a health worker was that if I was treating someone who was considered to be opposing to the government, I could be put in prison. And in fact, thousands of Syrian healthcare workers remain now in prison because of this law and because of the other sort of persecutions of these Syrian healthcare workers throughout this conflict. So my family's from Homs, and our home is actually opposite the National Hospital in Syria. And I remember this hospital from many visits in my childhood. What's important about this hospital and many other hospitals across Syria is they became a weapon in this violent, protracted conflict. So very early in the conflict, we knew that health workers were responsible for the torture or even the threats and disappearances of patients that had come in for treatment. And it goes back to something very important that Khuloud was saying about neutrality. So neutrality in this conflict, I would suggest, comes from a Western perspective of how we deliver humanitarian aid. As a health worker in the UK, I can be neutral and impartial in the care that I deliver to patients. However, we've certainly not seen that in the way that healthcare in Syria has been attacked recurrently and very deliberately across the country. In terms of the fragmented health system, a point that I would like to draw out at this point, which is very pertinent, relates to the COVID-19 pandemic. So if you look at the whole of Syria, there's been differential support in terms of PPE, so personal protective equipment, testing machines, testing equipment, the reinforcement of health facilities to be able to deal with cases. So the WHO has provided training and humanitarian aid and the testing machines, so the PCR machines, to the government of Syria, but most of those have gone to areas under government control. So, for example, none have gone to the northeast, which is the Kurdish-controlled areas. They have, however, received a couple of PCR machines from some of the Kurdish areas, and that's how they're able to provide some testing for that population. In the northwest of the country, so a population of about 4 million people, there is one PCR testing machine which has a maximum of 100 per day. And if you can imagine the number of patients that might present with possible symptoms of COVID-19, that's certainly not enough. And it speaks of the lack of infrastructure that we have now as a result of the protracted conflict. This is even more poignant now. So in government-controlled areas and in the northeast, there's been almost 400 cases of COVID-19 officially reported. In the northwest of Syria, until Thursday, there had been no cases, but the first case was reported in a doctor in one of the border hospitals between Turkey and Syria on Thursday. Should COVID-19 spread among this population, it's going to be catastrophic. Because many of the people within that area are internally displaced. Many are still living in tents and have themselves been displaced many more than once, particularly after the escalation of violence which occurred in the northwest from December 2019 onwards. So what does all of this mean more internationally? What's happened in Syria is very repeated and systematic undermining of principles of medical neutrality, and there's been consistent violations of international humanitarian law. So these principles have been codified since the late 1800s and became more formally enshrined in 1949. And they are there to ensure that all hostile parties do not use health and humanitarian workers as part of their attacks on civilian populations. In Syria, and of course, as we've heard in many other countries, and that includes Yemen, that includes Sudan, Iraq, Libya, even the DRC, so the Democratic Republic of Congo, and other countries where there are complex and prolonged conflicts, health workers have been threatened and have been attacked in the line of their work. The last thing I'm going to say regards the way that war has changed the structure and organization of healthcare delivery across Syria, but also in some of the Syrian refugee hosting countries. So within Syria, about half of Syria's population has been displaced. So pre-war, that was a population of 22 million. Now there are 6.7 million internally displaced people across Syria, predominantly in the northwest and the northeast. There are more than 5.5, so the official UNHCR figures are 5.5 million refugees, but of course there are many more. The majority of them are in Lebanon, Turkey, Jordan, and some further afield. So for example, there are a few 100,000 refugees in Germany. The important thing, and many of you will know that Lebanon now is a country facing massive economic collapse. So even for Lebanese populations, whether they are middle class, whether they are already poor and suffering, the situation for them is even more catastrophic. For Syrians, where more than 80% of Syrians live in poverty, the economic collapse in countries such as Lebanon is even more catastrophic and can push them even further into deprivation. And that includes healthcare, of course, but also the other social determinants that have a direct influence on the health of these populations. The important thing about these Syrian refugee hosting countries is many of them already had health systems that were strained within themselves, let alone taking in hundreds of thousands, if not 3.8 million refugees, as Turkey has done. I'm going to end by saying a few more words about Syrian healthcare workers. Something which many people do not realize is for Syrian health workers who are refugees in Lebanon and Jordan, they do not have the right to work. In Turkey, it's different, and there are provisions which allow partial registration for Syrian health workers, and for Syrians who take on Turkish residency and nationality, they are able to work in the Turkish health system, and that can be beneficial not only for the Syrian refugee populations, but also for the normal Turkish population. And of course, that has difficulties in terms of the retention of Syrian health workers, but also in frustrations, things relating to their education and development, and their ability to go back to being health workers should they be able to return to Syria. And of course, the last point relating to this is that we know that health workers who've been displaced to countries very nearby to where they come from, and this is often a deliberate decision on their part, they're far more likely to go back to their country of origin. And that's so important in Syria, because our health system in Syria, or rather our health systems, is going to need a great deal of effort to be able to provide healthcare for the population in the coming years. Many Syrian healthcare workers, so more than 3,000 or 4,000 Syrian health workers, so Syrian doctors, have registered in Germany in the last few years. And there's every chance that many of those, especially when they have families and children and are established in their profession in Germany, may not return to support Syria's health system. Of course, we would hope that they would. So I'm going to stop there, and I very much look forward to the discussion that's upcoming.
Thank you, Aula. So we're going to move into the discussion section of our webinar. Again, if you have any questions or comments you would like to raise, please write them in the platforms you're using. Having heard so many interesting interventions on the state of healthcare in the region, having heard about the situation in Palestine under occupation, in Iraq and Syria, and especially what seemed to really be emphasized across the four interventions was the issue of militarization of healthcare in the first intervention at the very source, and the weaponization of healthcare with time. And also I thought was very interesting the issue of erosion of trust in healthcare systems. And if I can also add, outside of sort of the direct influence of war, the massive privatization of healthcare and fraying of healthcare systems region-wide only adds to this difficulty. So the question we have to kick off the discussion, and I think Yazan has joined us, so we will say hello to him. Hello, Yazan.
Hello, everyone. Thank you so much, Anthony, for moderating. And I personally want to say a big thanks to all the speakers. I must say it was very fascinating and engaging to see all the linkages and issues that are being put on the table. Now, the question that I think we should kick off, because this is a lingering thing that I feel has been coming up more and more, and knowing what we know and knowing what we heard about the militarization of healthcare, the weaponization of healthcare, how healthcare is being targeted more and more over time. Can healthcare truly be neutral or objective? Is the idea of neutrality a very useful proposition to make about healthcare in this extraordinary situation? And what does this mean when war attacks healthcare in such a way? What does this mean about the image of neutrality in healthcare? So this is the question that we wanted to lay down on the table for you four speakers to start with. Omar, since we're adding everyone, it's good to see everyone. So I think the best thing to do is to have Ossama start, because it would be very interesting to hear from him. And then we'll see who else.
Okay. So thank you, Yazan. Well, coming from Palestine, it's very hard even to imagine medical neutrality. I think in like of course, like any other thing, in the global South has been shaped by either colonialism or settler colonialism. So even I think even the establishment of public health in Germany, you know, by Bismarck. The establishment of healthcare system was always made for big militaries, right? Even in Germany and in France and so on. So the caring of soldiers and so on was always an integral part of healthcare, and that followed the colonial troops into the global South and then state building and so on. So I think it would be, it depends on the context, but healthcare is no different to any other field of life that is shaped by the states that shape the country. So if we see our countries, our borders, our institutions, the political elites, the economical elites, everything has been shaped by colonialism and militarization. So it would be very, optimistic to dream of a nation state that is in our region, that is beyond wars and that can truly lay down the ground for a neutral healthcare system. I basically cannot see that in the near or far future in the region. And that has also, think, also the case regarding the USA and different and Europe, Western European countries.
Thank you so much. So Khuloud, you're next. What do you think about the idea?
I would say we're talking about two things. There's a humanitarian neutrality, and there's the medical neutrality within the medical institute. And the medical neutrality in the medical institute is you have to treat everybody equally, regardless of origin and regardless of their political opinions, regardless of their class, etc. And that's part of the medical institution, and you can call it neutrality or you can call it a mandate. But humanitarian neutrality was written by the most powerful. Humanitarian neutrality was written by the victors of the Second World War. So we need to redefine a humanitarian neutrality, definitely. But healthcare spaces are not neutral spaces. They are spaces of power. They are spaces of control. And there is no doubt that the state in Syria and the states in different states, use the healthcare spaces to show monopoly of violence, their own monopoly on violence, because these spaces are the most vulnerable. These are the spaces for the most vulnerable in the society. You're sick, you go to a hospital, your right to life is compromised. You protest, you get injured, you get shot, you go to a hospital because you are in a most vulnerable situation. Same if you are a prisoner. All of these situations are only examples of different vulnerabilities presented. And in these vulnerabilities, there is no neutrality, there is power. And in social sciences, there is nothing called objectivity, really. What is needed from health workers is to maintain their medical mandate.
Thank you so much, Khuloud. I believe next Omar wanted to respond to the idea of this.
Sure. Thank you so much. Thanks also for the panelists. It was really, really amazing presentations. Well, I mean, I think when we talk about neutrality, we are also talking about different things. So there is the neutrality that has emerged as Aula talked about during like a certain specific moment in time in history, as also Khuloud and Ossama mentioned, that actually these were certain kind of guidelines, and it never was a law. It was a kind of a custom that in war people have to respect healthcare workers, and actually not only healthcare workers, but also there's a range of different categories comes with the neutrality. Like, for example, you know, people, priests and sheikhs and Muslims and masjids and churches are all considered part of that law that talks about neutrality, that you don't really attack religious sites or religious figures. But, you know, with the kind of the whole Islamic State story and you know, that is really kind of completely, you know, it's a very different context here. But the issue is, as Ossama, kind of want to echo what Ossama was saying, that these were laws that were mainly defined for Western states. When these Western states were undertaking their kind of colonial wars, or they're, you know, dealing with Algeria, French dealing with Algeria, or the British dealing with India, these were not really seen as part of the neutrality framework, or the eventually later on the international humanitarian law. So if we look at neutrality in a historical sense, we realize that these are very context and historical frames, legal frames that when we put them in their own context, they fail to explain what has happened in the region. I'll give you other examples. Like we've definitely focused on the Syrian story, but let's say the use of polio vaccines to hunt down Ossama bin Laden, for example, and the rise of resistance to polio vaccination across Pakistan and even in Afghanistan, and I think even in Syria there were all these resistance. All of this has to do with certain kind of use and abuse of health in the practice of war, or in any of these political interventions. So historically, health in terms of politics are inseparable in many ways. Building states had to do a lot with providing health. It's a form of soft power. You know, others would call it biopolitics, whatever. But it's really a mode of organizing society. It's a way of also punishing and not punishing certain groups. So we can't really assume that health is by default a neutral thing. Having said that, I think there are organizing around the idea of neutrality as a mode of political pressure, or of a way to talk about human rights. That's a different kind of story, and I think Aula kind of really made that very clear in her intervention. So I feel like when there is a kind of a historical and a philosophical debate about neutrality, but then there is also more of how neutrality is used to push certain kind of agendas against human rights violations. So I think we need also to kind of differentiate between these two.
Excellent. So thank you very much, Omar. And actually, I think you very nicely frame this, because neutrality means more than one different thing. What I'm going to do is take a practitioner view of neutrality. So in the UK, as I said, I am so privileged. I treat the patient in front of me in a non-judgmental way. And actually, this is enshrined in my practice. This is our code of practice. And in fact, I'll be held to account if I don't, or if I can't do this. In Syria, we have lost that. So health workers, because of, I think, the lawlessness that has occurred across the country, even if they wanted to act neutrally with all the patients in front of them, they may be pressured by different militias. So I've heard horrific stories of doctors who are operating. So they may be operating on a child or a civilian, but they will literally be dragged out to operate on an injured militia person. And they will be threatened. And even if they are not threatened themselves, their family could be threatened. And all of this impedes medical neutrality. On a slightly larger scale, we know that in besieged areas in Eastern Ghouta, for example, that's one of the most horrific sieges that have occurred during this horrific conflict. We know that more than 50% of what was being sent in by different humanitarian organizations was taken out of the deliveries. And that's everything from insulin to surgical packs, anything that might be considered as inverted commas a weapon. And this is a complete violation of medical neutrality in these situations. And in fact, it left many people suffering and to starve in these areas. I wanted to pick up again on the health workers themselves who might have been operating with different organizations. I don't know if this has been common knowledge, but there is a Syrian doctor in Germany who is now being held to account for the torture and for the suffering that he inflicted when he was working as a doctor in Syria. And for me, this was so profound because it's so important for us to hold such people to account, because he certainly didn't act in a way that was medically neutral. One last point I'd like to make here is it's important to discuss neutrality. And as I said, we have different privileges outside of these war zones. And I say Syria, but it can also be Yemen, Iraq, and many of the other conflict-affected countries. But I think it's also important for us not to be it's important for us to be impartial. So, for example, we weigh up the evidence in front of us in terms of violations against healthcare, and we draw our conclusions, because there's a lot in these conflicts that isn't equal. And it's very important for us to challenge the narrative that often comes from the West in terms of the equality of responsibility when we discuss attacks on healthcare.
Thank you so much, Aula, for that. We're gonna take some questions we got from Facebook. So this is from Shireen, and she's asking, could you speak more about the weaponization of healthcare at the start of the Syria's uprising, from preventing protesters from going to hospitals to barrel bombing them, and the efforts by healthcare workers to create almost a parallel health system or underground hospitals and so on. So I believe, Khuloud, this would be an interesting question for you to tackle. If you can, briefly.
Yeah, it's a big subject, and I would imagine it's a project for a book. But health workers, when the protests started to happen in Syria in 2011, the response of the government, the level of violence used by the government and the security forces was different geographically, and there was in my opinion, there was a tactic behind that. But most of the protests were faced with intense level of violence. And as a result, right from the beginning, like right from the first 2 months, we had patients, in this case, injured protesters coming into hospitals. It was very quick for protesters and communities to realize that, okay, hospitals are not safe spaces anymore. And many of the doctors who were organizing in the political movement helped establish a network of field hospitals, but also a big part of the community actually participated in this. People and I don't want to say civilian, by that time wasn't militarized. So people, teachers, nurses, health workers, even the religious figures were involved in this. But I want to say a specific thing, because my experience with field hospitals and the network of field hospitals is basically the idea of a field hospital is all patients and all protesters, all organizers were referred to this space that is secretive and etc. It's actually a lot of the injured were treated in public hospitals and private hospitals under the government control, and areas under the government control, because of the resilience of the community. The network of people who were helping communities to respond to the burden of violence was massive. And before we had these networks institutionalized by humanitarian aid, of course, and the opposition government. These networks were rising, they were built down up, and they were based on horrifying experiences of violence against protesters in hospitals, and the use of healthcare workers as instrument of torture and also, unfortunately, torture and killing of protesters. Health workers, I think, who were part of the organizing found themselves in a situation where they had to change the hats immediately and work as health workers, provide medical care for people who were in need. The number of health workers who were killed in the beginning of the protest and the number of the health workers who were imprisoned by the Syrian government and the security forces is substantial compared to if you have a stratification of occupation across all the detainees and all those mortalities in the first 6 months. And I've looked at sets of data. It's way higher than any other occupation. So there was a massive involvement right from the beginning, because as I said, doctors, just as any other social carers, they are agents of change and they are social actors, and they were participating in this. As a result, the burden of violence on healthcare workers, I have been privileged to work with a lot of health workers, including myself. I had the experience of detention, and I worked with many who had the experience of detention, and detention, of course, started by the Syrian government and security forces, but then that was the tactic extended to all groups, unfortunately, all fighting parties. But these experiences of gender-based violence, horrific violations of human rights, and in that sense, the detention centers, unfortunately, are notorious for their reputation and dealing with, but specifically, and as Aula mentioned, health workers are now, all their work is identified as an act of terror against the state if they were caught to help anybody identified as working against the state. So whether under the government control and areas under the government control or opposition areas, there is a clear sentiment that you have a death sentence if you work in this. And despite the situation, thousands of people have worked and are still working. And it's actually a very amazing story of social action, of political action, and also for specifically in health, how a health worker can respond in these times.
Thank you so much, Khuloud. I believe, Aula, you wanted to jump in on this question of the experiences directly. Yes.
Absolutely. And it's very moving to follow after Khuloud. So obviously she has lived experience of this in all the most horrific ways that the healthcare workers in Syria have suffered during this conflict. I wanted to draw out some important things. So it's important not to forget the strength, resilience, and the innovation that Syrian health workers have been able to undertake. And that includes everything from innovating in terms of surgical techniques, using telemedicine, training in specialties and skills that are outside of their normal practice. And that includes medical students stepping up to run hospitals and deliver healthcare in the most challenging of circumstances. And also there's something that developed called siege medicine, where different innovations and different practices had to be put in place even very early in the conflict as a result of these. It's very poignant that the person asked the question has asked about barrel bombs. Of course, artillery shelling, snipers, in fact, all weapons have been used in the Syrian conflict, including chemical weapons. And there's been a recent report around this in the last few days. Barrel bombs are very poignant, and essentially what they are very large barrels filled with shrapnel, sometimes filled with chemical weapons, which effectively destroy a building. So you might take out the middle floor, collapsing the whole building. And that meant that Syrian health workers, even very early in the conflict, started seeing injuries that nowhere else would have experienced. There's no textbook as to how to deal with these injuries. So what happens is you don't only injure limbs, head, all the normal trauma injuries that you get, but you inhale all the dust from the building. So even if those initial impacts don't kill you, you will get a severe lung injury and then different infections. And like Omar importantly touched on, antimicrobial resistance and all the different pressures of infections happening after. And I have to say the Syrian health workers stepped up. And it's important to remember Syria had known peace for an awfully long time, albeit under strain, under political strain. And so the health workers that suddenly had to deal with all these surgical injuries had to learn how to do them. They had to learn how to do external fixations, all the complex surgeries, the different traumatic cardiothoracic injuries that they were seeing. And I have to say, Syrian health workers really did step up to the challenge very early in the conflict. And many Syrian health workers have stayed to continue to meet the needs of the Syrian population. One thing I'd like to say at this point is it takes a lot for Syrians to be displaced, to move from their homes. So my family is from an area outside of Homs where there was a horrific massacre in which 108 people, more than half of them were children, were killed in one night. But my family left the village that night, then they came back and they stayed for many years more. What drives people from their homes is when you start taking away healthcare from where they are. So they will stay if there is a doctor and a health worker and a health facility that will continue to provide healthcare for them. You bomb that health facility and that drives people to displacement and away from their homes. And you can see how very powerful these attacks on healthcare are in terms of population displacement and also demographic change, which has occurred throughout the Syrian conflict.
Thank you so much, Aula. I just wanted to remind anyone viewing this, if you have any questions at all, please put them on the YouTube link or Facebook. We're looking at them and we'll try to touch on any of them as best as we can. So I wanted to move next to a question we have, and I believe this will go to Ossama next to start. So in terms of understanding that healthcare is politicized, and we know that it is, let's say, compromised. How do you think, how should we engage with these healthcare systems that are often infused with agendas that are being imposed, whether by a state or a foreign settler colonial entity or a militant group? So what do you think about the engagement of these systems from either doctors or myself, who is not a doctor?
Mm-hmm. Yeah, that's a very tricky question. Thank you, Yazan. First of all, I really want to touch back on the issue of neutrality, because to continue what Aula said and to make it a bit more complicated, this argument of treating everyone, and of course this is this is crucial and this is should be taken for granted, but I think we should critically engage with it, because to see what it means. So because in Israel, this is in Israeli propaganda, this is very much used, right? The argument that Israeli hospitals treat Palestinian children from Gaza, or even Syrian, injured people from Syria are entered into Israel and getting treatment and sent back to Syria, and so they might say, you have it in the headlines that in Israeli hospitals they treat also the Jewish settler and the Palestinian activists and so on at the same, which might be true, but what does that mean? Does it make the healthcare or the political entity that the healthcare belong to better? And we should always reflect on what we see and what we don't see. The people who don't get permits to go into the hospital, and the people who are after the checkpoints, and that we don't see and we don't hear their stories, and the whole accessibility. And so if we would imagine a scenario where Bashar al-Assad led the hospitals in the territory controlled by the regime would take people from ISIS and treat them, what would that mean? Right? We should, I think, a bit be more critical in analyzing how that might be even used as a way to do public relations for the state and for the government, and to always reflect on what we don't see, who is not getting access to that healthcare facility and so on. In terms of engagement, I think this is a very important question that we deal with here often. We need to remember at the end of the day, people are people, and you need to find a job, you need to make a living, whether you're a doctor, a nurse, a pharmacist, so on, and you don't have the privilege usually of choosing from so many healthcare providers. So you start working in where you find a job, and even more if you're a patient and you want healthcare, and you just go to the nearest hospital or to the nearest healthcare. So in Israel, Palestine, this has been very tricky, because as I said, the healthcare was made for the Zionist project and for the settler working agricultural class. But then slowly we saw a rising class of Palestinian who became doctors, and where would they find a job? So and where would they work? Would you take that entire society and relocate it outside? What would that mean? People don't really want to voluntarily get out of their zone, especially when it's a conflict zone, right? The last thing you want to do is to get out and lose all of what you've accumulated, or you lose your land, or you might never return, and so on. So I think a human way of finding compromises and finding jobs is that, and also of patience. And I think here, especially the healthcare being a bit more neutral, being a kind of respected job, and so on. So it's usually something that people aspire to do, even in conflict region, and even with the not thinking too much and not over analyzing what is the political agenda of the institution I work on, because I think you might stretch that to every institution, right? Whether it's the education, whether you work as a school teacher in Syria or in anywhere, what would that mean? What is the body behind you? So I think it's a bit more complex, and I think there is a line to draw between working in healthcare systems and in other places, even in, so let's talk about ISIS controlled area. People did not choose to be subjects of ISIS or the subjects of the government held, I think, like in Syria. So they continue to work there. They don't completely, but there's a difference between working there and being an ambassador of the system. This is something that we need to critically engage in when doctors become the ambassador of the political entity that they represent. And I don't know about Iraq and Syria, but in Israel, this is very much used. And you see the use of Palestinian doctor also within the Israeli healthcare system in a way to try to whitewash the system, to show it. This is, of course, something that we can avoid and should not do, basically. Thank you.
Thank you so much. That was a very engaging answer. I believe the next person I would like to hear from on this question, if you'd like, I can repeat it to you, Omar, but I think you got it. You're on mute, so make sure you unmute. That happens a lot, people. Take it away.
Right. So I'll answer this question in two parts. So the first part is that it's what I was kind of trying to do, and I think I'll take what Aula actually kind of the diagnostics that she gave, that she said there is no one Syria anymore. There are different Syrias, a fragmented place. I think this is very central idea that health and healthcare is really part and parcel of state, kind of is seen, or at least is seen as part of state sovereignty. So when the Syrian regime responds in this kind of brutal and inhumane way, it is also responding in relationship to this idea that health and the health of the kind of the population under control of the state is something part of the sovereignty of the state. So health is kind of allows us to see how these things are fragmented in so many ways, and situates health in this kind of very important political question around the future and the situation of healthcare in these different conflict areas in the Middle East, in Iraq, and in many places. In many ways, building, in other words, I mean, building health and healthcare from start might be one of the first ways to establish a kind of a more functioning entities in the region. And I really kind of from reading so much history, you realize that this is a very central point. Now, how do you engage? One of the things, and I've had this conversation, I think, previously with Ossama before, personally, and even in more public settings. I think that in our region we have not really developed a very good platform using health as a form of a social movement or a way to do political and social reform. Health and doctors have always been tied to the state, have also been tied to their own classes within society. And a lot of the times they are also moved as kind of, I'm assuming that's the point that Ossama is kind of by also self-interest and their kind of class interest and social interest in general. So I think one of the really important points to think about in the future is how we can actually create social movement around questions of health and be able to demand political reforms, political transformation. And I think this moment of uprisings and revolutions is a very central kind of and critical event for us to reflect on that. I understand there are humanitarian groups, and I think Aula's kind of works with Sam has been kind of an incredible group doing humanitarian work in Syria, but I think this is where also brings back the issue of neutrality. I think we are not only about neutrality. Health and healthcare and doctors should not just be about practicing in a neutral setting. They actually have to be pushing to the improvements of the public good, defining health as a central thing that brings social solidarity together. This is a mode of improving the physical, the social, and the political body of society. So I feel like, indeed, health is a political entity, and in many ways, if we want to do politics, then health has to be at that kind of central stage. If we want to care for others and try to kind of transform the lives of vulnerable and marginalized populations and in the entire social contract, health needs to be at the heart of any kind of social mobilization. And I think it's probably time to have more doctors who think in that way. This is not necessarily unique. Historically, in Europe in the 19th century, social medicine emerged as a necessity, as a movement to provide better public health in different social settings. Even organizations like MSF, the organization started as a social movement of doctors trying to improve the health situation in different parts of the world. Now we kind of talk more and more about its role as a humanitarian organization, but originally it was a kind of pitched as an idea of a social movement. Another example is from Nepal. The 1990s revolution and the end of the monarchy was actually led by physicians. Ironically, in Syria, the current president is a physician, but this is exactly my point: is that we have lacked that kind of platform where physicians actually, where we can actually organize these social movements around questions of health, and the public good.
Thank you so much. Thank you so much, Omar. And you brought up some very interesting points that I would like us. We will touch upon it, I think, later on in this conversation. And I think you're going into very interesting points about the potentiality of healthcare beyond what we understand. I do want to mention very quickly that I'm not sure Bashar is a physician because he never graduated, did he? But that's something we can always talk about later. Now we're going to move on to a question from Facebook, and we got one from Fabio, I believe. And he asked about, and looking into dealing with things that could be politicized or compromised, he asked, may you address the effects of US sanctions, particularly the Caesar Act, on different healthcare systems in Syria? And I think that's quite a very interesting question. For those that don't know, the Caesar Act was created in response to of photos that have come out from a person called Caesar, who shows the torture and deaths of people in Syrian prisons. So there is an effect here. There is a call for justice. There's a tool here, and it seems to have an effect that could be negative. And I just wanted us to touch on these engagements. So Aula, I believe you will be next, and then Khuloud.
Okay, thank you. So just very briefly, I do think we need to be careful, and I would be very interested to hear what Khuloud has to say on this. We need to understand that the Caesar Act was put in place in direct response to the war crimes, and of course there have been many over the last few years of the Syrian conflict by the Syrian government and its allies. And there is wording in this act which seeks to target those responsible and hold them to account. There has been criticism saying it's a way to try and force the Syrian president out of power, but actually that's not the intention of this act. It really is to target those responsible. We have to remember that war is a very expensive business. The Syrian war would not have gone on as long as it has without millions, if not billions, of external funding going to the Syrian government and also its allies who've been supporting it. What I do want people always to remember is that there are bigger things at play. So for me, one of the most catastrophic things in terms of the health systems across Syria are the cross-border UN Security Resolution Councils, the cross-border resolutions. I just want to reiterate, so for the northwest of Syria, there are 2 border crossings. In the northeast of Syria, there was 1 border crossing which provided humanitarian aid from Iraq into northeast Syria. There was 1 in the south which provided aid from Jordan. Those last 2 were closed in January 2020. And for the COVID pandemic to the northeast, it has been catastrophic for the populations in that area. The non-renewal, and that's due to vetoes by Russia and China, who are allies of the Syrian government, could directly affect humanitarian aid to northwest Syria. And so I really do think we need to keep things in perspective and also not just focus on the Caesar Act, but also think about the other things that are at play. And that includes funding, that includes mechanisms which allow humanitarian organizations to maintain access and support populations. I'm going to hand over to Khuloud.
Yes, Khuloud, would you like to jump in on this question?
Yes, and I would say there are 2 issues when we're discussing the Caesar Act. The first one is that it's a US policy and it's made to serve US interest. So it's not a response to, it's basically a response by the Congress to showing these pictures and identifying these crimes. So how this will translate into better humanitarian response or drying up the sources of the regime, is this still an open question. But about sanctions, let's talk about sanctions themselves. Sanctions are a failed methodology. We've seen catastrophic impact in Iraq because of the sanctions. I lived in Iraq through the sanctions, and this was my childhood. All I know about my childhood, a lot of my childhood was defined by these economic sanctions on Iraq, and it's a different level of sanctions that based now on Syria. But there is the question of effectiveness of these sanctions when you have a state that is massively dependent on informal market, where you can't actually trap people who are accountable to the international law, or they do businesses in the straightforward way. So I don't know how effective is this to actually disable. There will be some level of disability to the Syrian government, but I have so many doubts when we're talking about effectiveness. And the second thing is that sanctions will definitely have catastrophic impact on the society in Syria. We're talking about already a very compromised population. There is no question that there will be an increase in further hardship and mortality due to sanctions, because economies don't work in a linear, one-dimensional way. People are connected, societies and communities are connected, and people will be affected by these sanctions, because in order to get to the informal economy, they will try to get to the formal economy, and this is the first impact of this will be on the population itself.
Thank you so much. So there is another question I suddenly saw on Facebook that I'd like to include. It's from Sausan, and I want to direct this again to Aula and Khuloud. And the question says, hi, would you agree with the fact that Assad actually waged a real biological war on the population by deliberately destroying and degrading public health infrastructure, preventing treatment of chronic disease and children vaccinations? Thus, the Syrian regime is reviving long eradicated diseases and killing even more civilians this way. Thank you for this discussion. Khuloud, would you like to jump into that, and then we can move to Aula?
Yes, I mean, you can call it different. There are massive terminologies to describe this level of violence and the conflict. You would call it biological warfare. You would call it necropolitics, anything, because actually it is very disturbing, the level of violence and how it touches on population health. Because initially it doesn't touch on population health. It does touch on population survival. So your right to life is basically in a question. I've worked in different organizations trying to get vaccines into, for example, besieged areas and areas in need. And the problem is that there is this militarized mentality where there is this belief that people will not lay weapons down until they see their children die. And when you get to this level of polarization, it is an elimination warfare. There is no foundation to have a rational discussion about infectious diseases, and if one community get an infectious disease, it will transfer to the other communities, etc. And therefore, I think there is to get into a point of addressing this situation, which we all hopefully are trying to do, is that there is no existence of any possibility of healthcare, reasonably fair healthcare, when you have this open war on people existence as communities and as individuals. So I absolutely agree. There are so many sociological frameworks you can look at and frame the war.
Thank you so much, Khuloud. I think you answered that perfectly, and Aula notified that she appreciates your answer and there's nothing more to add. Okay, so I'm going to try and go into an interesting question that I think Omar Dewachi brought up a bit, and this is a multi-layered question, and I wanted to ask, how do we pick up the pieces from a healthcare system that is shattered in the region? What is the importance of organizing on this front, and is there a revolutionary potential for healthcare and healthcare workers in this type of situation?
Thank you. Well, I mean, it's a complicated question. I mean, it's a bit of more like a prediction, or you know, which I don't really like, and especially in this moment of everyone is predicting things. But I think it has a lot of potential in many ways. I mean, I visited Baghdad last December, just before this kind of the COVID-19 epidemic, and what I really noticed and saw, that there was such a kind of an incredible energy with a lot of the younger physicians or the younger students who have been camping in a place like Tahrir, providing support to the protesters, dealing with injuries, dealing with all kind of everyday illnesses that people, because, you know, in Baghdad, Tahrir has become a kind of a mini city where people just really sleep and live and kind of dwell in. So we're seeing kind of these elements. A lot of the physicians and the doctors went onto these demonstrations and protests. There were like kind of brigades of physicians moving through the you know, the streets during the different moments in the protest. One of the main things I feel is important is medical education, something that I've been doing for a long time before I kind of moved to the United States. But in Beirut, I've taught social medicine and global health for about 14 years, and this is kind of, I feel, one of the main places to start doing that. My strategy was to try to show physicians, or these kind of wannabe physicians, or the young kind of medical doctors, is that there are other ways. There are many ways to imagine yourself as a doctor. It doesn't have to be just like this person who's working in a hospital or in a private clinic, or, you know, you're gonna take over your father's surgical practice, or your mother pediatrics practice, or what have you. Which kind of what I saw in a lot of the students that I taught. The foundations of understanding the centrality of health in the as a public good and as a central social kind of platform, it needs to be taught at a very in a very integrated way for medical students. One of the things what we try to do is to bring in people from MSF or from the ICRC, just to give the student an opening to see that you can be something different than just a kind of a physician who's suspended in the economic structure of the private healthcare system in the country, or something like that. So I think we definitely need to invest in the newer generation of doctors. We need to kind of also allow these doctors to have a better historical consciousness around what has medicine done in the past in other places, give examples. We teach, and this is why social medicine and history of medicine and medicine and humanities are so important. Medical education, at least, and it's not a prevalent thing, but it is there in some really kind of interesting medical education experiments. So I feel like that is one element that needs to be invested in, and I think we need to also begin to really think. Again, I come back to this issue around the public good, because I feel one of the biggest kind of assaults on society health and on environmental health and has been the kind of the pushing privatization, pushing the public sector, undermining it through, you know, war or through neoliberal policies. These are global trends that we are seeing that has been undermining healthcare. And actually, the more these things are undermined, the more even these doctors will continue to seek their survival over trying to think about a broader idea of what is the public good and what is your role as a physician in that. the role as, again, so I think the role of doctors needs to be incorporated more, or healthcare workers. I'm talking about doctors as a kind of, maybe it's a wrong way of framing this, but in general, healthcare workers in general, nursing, physician assistants, dentists, all of these, the staff, we need to reimagine what does it mean really to practice in settings of war, but then also where do we move from there? And I think kind of also this is a kind of an issue that we tried to really focus on in Beirut when I worked with my colleague Ghassan Abu Sitta on conflict medicine program, is to also bring back the issue of that our region has a certain experience and expertise in these kind of conflicts. And in many ways, we need not to always orient ourselves to what the textbooks are saying in America or in the United Kingdom, or, what is the universal thing in the West, but actually try to understand disease as a local phenomena and build our kind of expertise and knowledge and thinking around kind of a bottom-up approach in many ways, even through basically trying to figure out what does medical knowledge mean, practicing it from our own kind of position in that part of the world.
Thank you so much, Omar. I wanted to continue with the question we asked, but I wanted to fold it into an excellent comment on Facebook that was also seconded by another commenter. So the comment was from DreeQ, and she said, "Thank you to all the wonderful speakers. There were a couple of references to how war healthcare is frequently gendered. I have a rather specific question. State-sponsored pro-natalist reproductive policies typically accompany war and so-called post-war time, which of course target women mainly. This is usually a very gendered and ethnic process that requires willfully adopting and funding a healthcare policy." I'm missing the rest of the question, but I think we, to fold it into what we're saying, and I wanted to ask Khuloud and Aula's opinion. When we're trying to reimagine and picking up the pieces of our healthcare systems, and especially the revolutionary potential, considering that healthcare is super gendered, in the process of repicking that up, how can we not fall into the same traps of patriarchy and the same modes that usually target women in healthcare and harm them? And we can think of multiple ways how healthcare has been weaponized specifically towards women, not only in terms of war, but also in quote unquote peacetime. So I think it's quite important to hear. Let's start with Aula.
Yes, well, I'm actually very keen to hear what Khuloud has to say about this. I think this is a really interesting question. And I'm also interested by the fact that the person asking the question actually focuses on state-sponsored pro-natalist reproductive policies. As we've said, different parts of Syria are under different types of control. And sadly, what we've seen in Syria is the growth of more stringent Islamic thinking in different parts of the country. And I think that has had a direct impact on gender, on reproductive health, and issues that are related. In terms of the kind of policies that relate, I think it's different in different parts of the country. So we know that, well, from very little that we know of what was happening when Daesh was more prominent, in the health system that it had developed, we knew that there were some very bizarre stories that were atypical for Syria, where a male physician couldn't treat a woman, or if they did so, it was all very bizarre. There were mirrors involved, and it made no sense to anyone how you could practice healthcare in that situation. And I don't think they allowed women to practice as doctors, for example, or if they did, they were very restricted in what they could do. Moving to, for example, the northwest of the country, sadly, what I've seen in the last 9 years is increased conservatism in some of the areas, for example, in Idlib and surrounding areas. And of course, that has an impact on gender and the roles of women, the training of women, but also on what sorts of reproductive healthcare and maternal healthcare is available to the population. In terms of these things, I think it's a very changing situation. One thing that would be interesting, so for the moment, we're actually looking at a project just simply on C-section rates. And this is actually a very complex situation across the whole of the country. And some of it will have perhaps, different attitudes to women are going to influence this. And of course, this preceded the war. And of course, the actual war itself made it very difficult. So, for example, women might prefer to have a C-section. So in the besieged areas, because of the paucity of healthcare, about 70% of births were actually delivered by C-section. So the WHO says it should be more like 15 to 20%. What is interesting is in the northwest of the country, the rates seem to be 20 to 25%. In government areas, I've seen rates of 50 to 60%. And it's very interesting to tease out how much of that is policy and all the other social determinants that have an influence on this. So Khuloud, over to you.
Thank you. Very important, Aula. We can talk about this C-section. I can talk about this for hours. About the questions of the postnatal policies, there are historical case studies for this, but we didn't see yet, at least for me with my very humble exposure, I didn't see yet anything like this in the government-controlled areas, at least. But there are gendered phenomena of healthcare that are very interesting, I think would be for sociologists and anthropologists. Since the last time I've been to Damascus, and then I've seen pictures and work on it, the rise of plastic surgeries among women is extraordinary, and the market for it is exploding. And you walk in Damascus where people can't, some people can't afford bread, but you see all these marketing about plastic surgeries, and we've seen some kind of trend like this in Lebanon also before. But back to the gendered nature of healthcare workers and healthcare itself, there is no doubt that this is a universal situation where always women are identified with giving the care and having this role where you nourish and you take care of the patients, etc. But also, when you look at the structure of healthcare everywhere in the world, you will find that actually women, although they compose up to almost, in some areas, up to 80% of the working force, they all concentrated in the lower ranks. They're all concentrated in caregiving. And when you look at policy-making level, you almost never see a woman there. It's always been taken by the men. And I think this links to the case where Omar was talking about, and also Ossama was talking about. We can't look at healthcare itself as a political space. This is a space of power. So if you want to shift the gender balance, you shift the gender distribution in a healthcare, you need to give it back its power. You need to acknowledge that it's a political space. You need to see the role of doctors and nurses and providers, not only as healers and providers, but also as social actors and actors of change. In our case, we're hoping that our crisis, as it destroyed societies and broken communities, but also it's an opportunity for us to bring on a momentum to identify what is the public good in each of these societies, what we agree on, what we need to protect, and what is the future, what can be done in the future to protect this and never return to the point of this level of polarization and violence.
Thank you so much. Ossama, would you like to touch on the question about picking up the pieces and the importance of organizing? How do we pick up the pieces? Is there a revolutionary potential for healthcare?
Well, I think yes, there is indeed a revolutionary potential for healthcare, and but it also it deals with it touches on sovereignty, right? So in these war-struck regions where people, at least like what I'm seeing in Palestine, don't really have an opportunity to sit up and really sit together and talk about strategies for recovering healthcare and so on. It seems like a dream, and we should know that people do come from different places and come and have different agendas, and as we've seen, healthcare is a tool for political power. So it's not like everybody enters the room and how can we create the best healthcare for everyone, and this is the discussion, right? It's usually not. And so especially in like my experience in Palestine, there is no social contract even, right? Like where the country does not exist even. It has been colonized, it has been militarized, and then you have the PA, the Palestinian Authority, that does not truly govern and does not have sovereignty. So there is no social contract between the state and the people. And I think this might be relevant to post-war, Iraq and Syria, how this social contract is being shaken. So people don't know, what do I deserve as a taxpayer, or what should I get in return, or should I go to the private section, or should I go to do medical tourism, which like Omar's book has touched upon, and so on. And again, also for doctors, most like I'm trained as a medical doctor. Most doctors are trained as technicians, right? We are trained to whether to operate or to work on to treat this bacteria and this infection and so on, and not to really think as political leaders and as political agents. We are trying now to establish, like in Palestine, it doesn't exist even a unit for medical students or for Palestinian doctors. We were planning to have a conference which Omar was supposed to speak on, but it was delayed because of COVID. I think it's hugely important to try to organize, especially younger generation of doctors who are now being more affected by the political situation, and their future career and work condition depends on that, in order to envision a common future and to break to try to connect the dots. But for now, everything seems so fragmented, and I think it also can be done from outside in a way that if we talk about the responsibility of NGOs, not just to start another clinic and another medical project, but to really do a screening of what is there on the ground and how can we connect all the different initiatives on the ground to facilitate their cooperation together, and so on.
Thank you so much, Ossama. And I want to thank everyone else that participated in this wonderful, wonderful discussion. I would thank you so much for your endurance. We've been doing this for 2 hours, and I would like to thank the audience and the people behind the scene, of course. There's Yasser Bonif, who's been the technician, and Anthony, who is very nicely and kindly moderating in the beginning. I think there's one thing to say, at least from me as perhaps the only non-medical person here that has flirted with the medical sector in various ways, that it's clearly, at least from my perspective, how important this conversation is. And it is important in terms of its intersectionality, not only in terms of space and time, but in theme and geography. I mean, these things matter not only for Syria or Iraq, it matters for Palestine, Bahrain, Yemen, as you mentioned, in other places, Aula, like Afghanistan, DCR, CAR. And it matters to each of us at home, where we're sitting at, as we can see with the pandemic. These questions, when we're looking at in terms of war shaping health, is also questions about how peacetime shapes health. Because we see things that bleed in, whether it's the militarization of healthcare that we've seen with the pandemic, or the gendered levels that have happened in healthcare because of patriarchy, or the fact that there are inequalities of access. So I think if there's one thing for us to take away with this discussion we had today, is how this topic of health matters for all of us, universally, wherever we're at. And it's not just limited to spaces in the distance elsewhere, in spaces that are hidden or beyond or facing extraordinarily hard, brutal circumstances. They're for all of us. So this is Yazan Asadi signing off, and I would like to thank everyone else once more for joining us in this brilliant conversation. I look forward to having more and more types of these public conversations on health and war in our region. And hopefully, may I say, that I hope one day we can actually have a revolutionary medical force where we don't need INGOs in this region, and we do it ourselves. Because I've seen in my trips in Iraq and Yemen and other places, there is a need, and we need to do this. And hopefully one day, whether it's you guys on the screen or people hearing in or whoever else can do it, we can do it together. Thank you very much, everyone.
Thank you very much.
Thanks.
Thank you.
Bye.